Okay, Nursing 435, Week 2, Part 4. Intrapartum complications. Sometimes there can be complications in labor and delivery. The first one would be chorioamnionitis, and we mentioned that just a little bit in class. It's a bacterial infection in the amniotic cavity occurring in 0.5 to 10% of pregnancies. Usually diagnosed by clinical findings like maternal fever, maternal and fetal tachycardia, uterine tenderness, and foul-smelling amniotic fluid, and it's a very distinct smell. Most often occurs after the membranes rupture, although it can occur before the membranes are ruptured where bacteria actually penetrate the amniotic sac. Risk factors include long labors, prolonged membrane rupture, multiple vaginal examinations, use of internal fetal heart rate monitors, and contraction monitoring modes. So in other words, the more you put in there and disrupt that fetal membrane, the amniotic membrane, the more risk you have. Other factors include young maternal age, low socioeconomic status, nulliparity, and pre-existing infections in the lower genital tract, things like bacterial vaginosis, chlamydia, gonorrhea, those kinds of things. Can develop bacteremia from chorioamnionitis, where mom gets a systemic infection, more likely to have dysfunctional labor, which results in a C-section, wound infection, or pelvic abscess. Neonatal risk are pneumonia, bacteremia, and sepsis. Not uncommon for babies to be septic after they've been exposed to chorioamnionitis. Death is more likely to occur in preterm rather than term infants, again because of their developmental stages, less immune protection. There is an association between chorioamnionitis and long-term neurologic development in the newborn, including cerebral palsy has been reported. And as you remember, that's one of the goals, is to reduce the incidence of cerebral palsy, especially in preterm babies. Dysfunctional labor is another complication, or dystocia as we call it, defined as long, difficult, or abnormal labor caused by various conditions associated with the 5 factors affecting labor. You can have abnormal uterine activity, hypertonic uterine dysfunction, where you have strong, uncoordinated contractions that don't produce the effacement and dilation that you hope for, or hypotonic uterine dysfunction, where the contractions are not strong enough to affect a change and progress in labor. The secondary powers, or the bearing down, can be a problem. This sometimes occurs with an epidural or spinal anesthesia. Mom can't feel that urge to push, so she doesn't. And abnormal labor patterns can just be a number of things. All contribute to dysfunctional labor, or dystocia. Prolonged latent phase. You can have a really long latent phase. You can have a secondary arrest where there is no change in dilation. It's just she's not progressing. She may get to 5 centimeters, for example, and stop progressing. Protracted descent. The baby may be moving down through the birth canal, and all of a sudden it's not coming down anymore, or it's very, very, very slow to come down. Or it can just stop, or arrest of descent. And then failure to descend usually indicates that the fetus is not going to fit through the pelvis, so it can't even enter the pelvic inlet. On the opposite end, there's a precipitous labor and delivery, which is labor that lasts less than 3 hours from the onset of contractions to the time of birth. It's about 2% in all the births in the United States, but it can be quite traumatic, both emotionally for the mom and for the family. These are the ones that deliver in the car on the way to the hospital, deliver at home before EMS gets there, or they walk into the hospital, they get put in a bed and deliver before anybody can come, the physician can come and see them. The precipitous labor can be caused by hypertonic uterine contractions that are tetanic in intensity. In other words, they contract and just prolonged contractions that are they never go away, which can cause placental abruption, or the placenta prematurely separating. There's an excessive number of uterine contractions, or recent cocaine use can also cause this hypertonic uterine contractions. Maternal complications include uterine rupture, where the uterus actually comes apart. Usually it's at the lower uterine segment or the site of any previous uterine surgery like C-sections or any kind of surgery on the uterus, such as fibroid surgery. Lacerations of the birth canal, especially in a precipitous delivery, the baby comes out so quickly that it's just can lacerate the birth canal, make vaginal lacerations, cervical lacerations. Anaphylactoid syndrome of pregnancy used to be called amniotic fluid embolism, and as we talked about last week, there are a number of substances in amniotic fluid. It's present in all amniotic fluid, and the reason they changed it to anaphylactoid syndrome of pregnancy is because they've done studies. The research shows that most women have this debris in different parts of their body, say in their kidneys, but they don't have reactions to it. Only certain women who have these anaphylaxis reactions are actually at risk for death. Most women aren't affected by it. Postpartum hemorrhage can be an issue as a complication, where the uterus fails to contract, or there could be lacerations that are not known. Fetal complications include, malposition, malpresentation, fetal distress, nuchal cords or cords around the neck, any number of things. Alterations in pelvic structure. Mom could have had a pelvic fracture, or something like that. Pelvic dystocia, soft tissue dystocia. In other words, any part of the passageway can be affected that can cause complications during labor. Some fetal causes are anomalies, so birth defects, things like hydrocephalus, myelomeningeal or spina bifida, gastroschisis, where the intestines are on the outside of the baby's body, conjoined twins. Cephalopelvic disproportion, or CPD, is simply the head and the pelvis don't go together. The head will not fit through the pelvis, and that will cause that arrest of descent or failure to descend. Malposition, which includes breech, occiput posterior, malpresentation, multifetal pregnancies. Twins nowadays are pretty much not delivered vaginally unless it's an emergency or unavoidable, and that's because typically the second twin is likely to get stuck, and we don't want to have that kind of problem. Abnormal presentations include a face presentation, and there's a slide with pictures on it, and where the face is actually presenting first rather than this part of the head. The face is actually presenting first. It can be a brow. The baby's brow is presenting. It can be a breech, and we talked about that, either footling, buttocks, or both. It can be a shoulder presentation from a transverse lie, where the baby's lying transverse to the mother. And then there's a picture of the different types of breech. Frank breech is both legs are up and the buttocks are down. You can have a full breech and a single footling breech. There's also a picture, another position picture in a delivery. And the final slide is a picture of a pelvis that indicates LOP, LOT, LOA, OA, ROA, ROT, ROP, and OP. And it has to do with where the occiput of the baby is in relation to the mother's pelvis. In other words, LOA would be left occiput anterior, so the baby's occiput, or the back of his head, is on the mom's left side and the occiput is anterior or he's face down. So you can think about that as you think about labor and delivery. Okay, thank you.